regular practice and how to face off our Viva and everything. So, starting with with my introduction, I am Avika Parazuli, a fourth-year medical student in Gandhiki Medical College, Pokhara, and now I'd like to proceed on into the rules of the session. I'd like to request all of the learners in order to join by their good name. I'd like to request all of you not to interrupt in between the session. The question and answer rounds will be proceeded after the presentation. Now, without further ado, I would like to introduce our esteemed professor, Dr. Piyush Gupta, sir, MD, FIAP, FNNF, FAMS. He is the HOD, Head of Department of the Pediatrics Department, Principal and Professor of University College of Medical Sciences, Delhi. We would like to heartily welcome to you, sir, in this webinar.
Thank you.
In along with his contribution to the medical fraternity, he is also the chief editor of the PG textbook of pediatrics. We are blessed to have your presence over here today, sir. Thank you so much. Now, I would like to introduce to our presenter, Mr. Ravi bashyal, MBBS final year from UCMS Bhairahawa. Are you there, Dai?
Namaste, sir.
Thank you so much. Now I'd like to give this floor to our presenter, Mr. Ravi bashyal.
Am I audible?
Yes, you are audible.
Thank you, Avika Baini. Thank you, sir. Also honor to have you here.
Thank you, Ravi. And it is nice to connect with you all. Before beginning the session, I just have one query. What is the duration so that I can pace accordingly? Duration of the session.
Duration would be 1 hour.
1 hour. Okay, perfect. So it's UCMS versus UCMS today.
Yes,
Ravi is also from UCMS in Dhahran and I am from UCMS in Delhi, India. So let's have a good time and let's try to learn from the case as far as possible. And thank you to the Grey Medicos for giving me this opportunity. Abhigya said about the PG textbook of pediatrics. I am happy to share that tomorrow we are going to release our UG textbook of pediatrics on the same lines of PG textbook of pediatrics. It's a 1 volume only, not 3 volumes. And UG textbook of pediatrics, totally competency based and to the tune of what all UG needs, with a plenty of color photograph, with plenty of case studies and flow charts. Means because now it is learning through the competencies. So that will be tailored to that. I hope within a month it will be available in the market. Thank you. Thank you so much. We can now proceed with the case.
That's great. So now we would like to proceed on.
Yeah, I think Ravi has some connection issue. He has.
Vidai, are you there?
If he's not there, I can present on his behalf because I have his presentation. Let's see if he joins back, or I'll play his presentation and we can start. Just let's wait for, I'll also see if I have the presentation with me.
Yeah, is back there now.
Yeah, Ravi. Please start.
Dai, your mic is mute.
Okay. Sir, sorry for there was no disturbance. Sir, may I proceed, sir?
Yes, sir. Please.
Okay. Thank you, sir. Is the screen visible?
Yeah, your screen is visible.
Okay. Once again, thanks a lot, sir. We are waiting for 1 year for your webinar, sir, and finally today we got a chance to present in front of you, sir. Today I am presenting a case on portal hypertension. My patient particular, here is the case of Mr. X, 5-year-old boy, Muslim, literate, studied at LKG, resident of Pudol. First one child out of consensuous marriage. Informant was mother. History was reliable and there was no language barrier. presented to UCMS TS on 2023, January 28, and today the date of examination was January 29, 2023, and mode of admission was via emergency. And the chief complaint was vomiting of blood for 1 day and passage of black color stool for 1 day.
Okay. Can I interrupt you here?
Yes, sir.
Yeah. So Ravi, I understand with this chief complaint, the child has an acute duration or acute illness. Is that correct?
Yes, sir.
Are you doubly sure that the child, what does this mean? When you say the chief complaint is for 1 day, that means that this child was perfectly well 1 day back. And before that, there was no trace of similar illness, same illness in the child. Is that correct?
Yes, sir.
There has been no past history of vomiting of blood.
Yes, sir. There was.
Do you think that vomiting of blood was due to a different reason and this is due to a different reason? Or is it the same illness?
It is the same illness, sir.
Then your chief complaint, my dear, is not 1 day, because the illness is not for 1 day. The illness is persisting for long. When was that episode?
Sir, before 1 year, sir.
So if I understand correctly, this child has had 2 episodes of blood vomiting. One was 1 year back and second is now. Is that right?
Yes, sir.
Okay. So my dear, please understand that in this case, the complaint will be, the chief complaint will be vomiting of blood, 2 episodes, the first 1 year back and the second 1 day back. Do you understand?
Yes, sir.
Why this is important? See, once you are giving a vomiting of blood for 1 day, it implies an acute illness. Acute illness, most commonly vomiting of blood, why would it occur? The most common cause will be some gastric erosion, isn't it?
Yes, sir.
And if you are stating that the vomiting of blood is recurrent, has been occurring again and again, that means there is something wrong in the GI tract. And it is for long, almost for 1 year. So it will make a difference in your hypothesis presentation. The chief complaint does not necessarily mean what the patient says. You also have to interpret in the light of the illness. So this child was well 1 year back when he had first episode of vomiting of blood. In between, the child remained well, and 1 day back, again, the child had vomiting of blood. That's how you should present this history. Okay?
Okay, sir.
Yeah, please go ahead. Past history, if you had written that complaint in the past history, it is wrong. The past history means any history which is suggestive of a past illness. In this case, it is the present illness only, which is continuing. So it is not a past history. It is a part of the history of present illness. Yeah, please.
My history of presenting illness, according to mother, he was apparently well 1 day back. Then he developed vomiting of blood 1 day back without nausea, non-projectile, 7 to 8 episode, fresh clotted blood, around 5 to 10 ml in each episode, with no foul smelling, with no any ingested food particles, with no aggravating and relieving factor. It was associated with mild abdominal pain.
Please proceed, complete your history, then we'll come to this.
Okay, sir. Mother also noticed of phases of dark black and terry color stools 1 day back and was not associated with mild abdominal pain. There was no history of passes of fresh blood in stool before, during, and after defecations. No history of always discoloration of the body. No history of blood with sputum. No history of use of aspirin, warfarin, and steroid. No history of anorexia, weight loss. No history of heartburn and regurgitations. No history of difficulty in swallowing. No history of bloody diarrhea and mucus in stool. No history of discomfort, bloating, and nausea. No history of altered sleep pattern, flapping tremor, altered sensorium. And no history of violent passes of vomiting before development of vomiting in blood, no history of fever, no history of bleeding from gums, no history of bone pain, no history of abdominal distension, no history of constipation, no history of hematuria or oliguria, no history of abnormal body movement, no history of palpitation, and there is no history of cough and dyspnea. He had a history of vomiting in blood 1 year back and was relieved with blood transfusion and medication.
As I said earlier, that this is part, if you think this is part of the same illness, that means the child has something due to which he is bleeding again and again. I give you another example. You all must be aware of nephrotic syndrome, isn't it?
Yes, sir.
How does nephrotic syndrome present?
Nephrotic syndrome present with, sir.
Nephrotic syndrome does not present with hematuria. Can anybody write in the chat box, or how does nephrotic syndrome present? You can write in the chat box. I can read it there. How does nephrotic syndrome present? Anasarca. Excellent. So there are messages, periorbitals, very good. So all these messages are that it presents with edema. Okay, whether it could be periorbital swelling, it could be pedal edema, it could be proteinuria is not the symptom. Symptom will be edema. So suppose a child presents to you with nephrotic syndrome with history of edema for 1 day. And then you ask, and then the mother will tell you, sir, this child is having repeated edema at the interval of 2 to 3 months for last 2 years. So how are you going to present your present history? So your history of chief complaint will change. It will be repeated episodes of edema for last 2 years, not that edema for last 1 day. Because what does that tell you? That tells you it is a chronic illness. It is an illness which has repeated or recurrent edema. It is an illness which is normal in between the episodes, and then it has flares up in between. So it clearly gives you an idea that this is a child with nephrotic syndrome. Okay. So here he is history of vomiting in blood. So let's complete the history, then we will come back to your negative history.
Okay, sir. In my birth history, in prenatal history, in first trimester, his mother pregnancy was diagnosed at a center by urine pregnancy test after 1 month.
Anything important in prenatal first trimester history which you specifically want to ask about?
Sir,
yeah. Which has or which may have a relation with the present episode?
Sir, there is no such. All the event of prenatal history was uneventful, sir. Was found.
Okay. So there was nothing specific that you wanted to. It is important. Why? What all is important? This child is having bleeding episodes, isn't it?
Yes, sir.
So this child could be having a coagulopathy.
Yes, sir.
Don't presume it is portal hypertension, because you are knowing the diagnosis. That is the worst thing. You have to broaden your scope. Let's go back to your first slide. Now let me ask you, if a child presents with vomiting of blood, 5-year-old child, what are the causes you will think of? Tell me of the various causes you will think of.
Yes, sir. Initially, I will.
You can write people. The others can also participate. They can write in the chat box. I'll read them out.
Sir, I will initially suspect of involvement of GI, gastrointestinal system and the hepatobiliary system, sir. In this system, I will be suspecting peptic ulcer disease.
Peptic ulcer disease, okay, or acid peptic disease. Good. What else?
Yes, sir. There might be, sir, esophageal spasm might be there.
Sorry, I didn't get you.
Sir, varicose bleeding might be there, sir.
Varicose bleeding, okay.
And then
that somebody has written in the chat box also. What else?
There might be obstruction.
There could be bowel obstruction. Yes, bowel obstruction could lead to this GI bleed. What else?
Sir,
think of more causes in a child 5-year-old. Inhaled foreign body will not result in bleeding. Chest trauma, no. These will not result in think of acute things which can result in bleeding. Okay, I'll tell you one most important thing is caustic ingestion. I don't know how common this is in Nepal. In India, it is very common, the caustic or the corrosive ingestion, because these are used as cleaners in bathrooms and children drink them. So that is one important cause. The other is drugs ingestion. Then the two important causes are Henoch-Schönlein purpura and Crohn's disease. Somebody has written necrotizing enterocolitis. See, this is a 5-year-old child. Necrotizing enterocolitis you see only in preterm newborns. So it is not a cause in this age group. AV malformation, no AV malformation will not, it is the portal vein malformation, rather, which will result in varices and bleed, not general AV malformations. Okay, then you can have vascular anomaly. Yes, AV malformation too. You can say blood dyscrasias. Yes, definitely some coagulopathy can result in bleeding from mouth. So these are the various causes which can result in this bleeding episodes. Then because of the portal hypertension, it could be variceal bleed will occur because of portal hypertension. Portal hypertension could be intrahepatic or it could be extrahepatic. Extrahepatic can be either prehepatic or posthepatic. I hope everybody understands that. Okay, so extrahepatic and intrahepatic need to be differentiated very clearly. Mallory-Weiss tear, yes, Mallory-Weiss tear is a, but that is again with a very forceful vomiting, and Mallory-Weiss tear does not result in repeated such big amount of blood that is coming here. So these are the, now what all you should ask in the history. Whenever you have a child who is coming to you with GI bleed, with upper GI bleed, what all you will ask in the history. Ravi has done a good job. He has asked for several points. So, but I like to know from all of you, what is your take, what all you should ask. There are 5-6 important things. The most important thing is the color of the bleed, amount of the bleed, frequency of the episodes, and any history of previous episodes, which he has asked. What else? Then you have to ask whether it was a painless bleeding or a painful bleeding. Painless bleeding occurs in coagulopathy, Mallory-Weiss tear, polyps, vascular malformation, and esophageal varices. It's a painless bleeding. But if it is a gastritis, it is a esophagitis, it is some ingestion, foreign body ingestion, then it may result in a painful bleeding. And preceding retching or forceful emesis always points to a Mallory-Weiss tear. A history of abdominal distension is important because that will tell you about some bowel obstruction or other things. Stool, you have to ask about, like, this child has a history of passage of black colored stool for 1 day. So you ask about the frequency, volume, and consistency of stool. Now this black colored stool, you have to differentiate whether it is melena or whether it is dysentery. Because in the dysentery, it will be with blood, mucus, and crampy abdominal pain. Here, there was no abdominal pain. So it is more likely to be melena. Then you have to ask about extraintestinal manifestations, such as I told you, you should always also consider Crohn's disease. If you consider Crohn's disease, then you also have to ask about extraintestinal manifestations such as joint pain, aphthous ulcers, fever, weight loss, and skin lesions, rashes, somebody has said very rightly. Then history of intake of any drugs. Most importantly, non-steroidal anti-inflammatory drugs, anticoagulants, antiplatelet agents, iron can also result in GI bleeds. And then there is a history of recurrent infection. History is suggestive of congenital or acquired immunosuppression such as CMV and polymicrobial typhlitis. And past medical history, intake of any drug. So these are the important things to ask in the history. Henoch-Schönlein purpura, yes, ask about rashes, Ask about the joint pain, abdominal pain. These are important things to be asked for. Can we just see your negative history so that we can dissect it? So can you tell us, Ravi, why this no history of passage of fresh blood? So this rules out dysentery.
Sir.
Yeah.
Yes, sir.
So you like to tell us, please, you go ahead.
Yes, sir. So initially, we suspect there is vomiting in blood, sir. So to exclude that things, I suspect there might be upper GI bleeding or lower GI bleeding. To exclude lower GI bleeding, I have asked about negative history over here, and that there is no history of passage of fresh blood in stool before, during, and after defecation, sir.
Right. Please go ahead.
And then I asked about no history of yellowish discoloration of body to rule out the hepat causes, sir. There might be obstruction over there. To rule out I have asked about yellowish discoloration of the body, and then no history of pleural sputum. To differentiate.
Why did you ask about yellow discoloration of body? It's which obstruction you are talking about?
Yes, sir. Post-hepatic obstruction, sir.
No, don't. See, you are going in very specific. Now you are asking about history of jaundice, isn't it?
Yes, sir.
So basically you want to know whether liver was involved or not. This liver could be involved because of parenchymal defect. That means some cirrhosis in the liver, problem in the liver, or maybe post-sinusoidal also some jaundice can occur. Okay, but there will be no jaundice in extrahepatic kind of portal hypertension. So that's why basically jaundice we want to know about the liver involvement. Okay.
Yes, sir.
Yeah, please. Drugs, anorexia, weight loss. Yes.
Yes, sir. And then no history of heartburn and regurgitation, sir.
Why that?
Sir, to rule out peptic ulcer disease, sir.
Anything else you want to rule out other than peptic ulcer disease? This is an older child, 5-year-old.
Yes, sir.
Suppose this had been 1-year-old child and history of regurgitation, what would it suggest?
Sir, there might be congenitally some defect might be there, sir. Congenital or
anything other than that? In that age group, you should also think of gastroesophageal reflux disease.
Yes, sir.
Sometimes that can occur in, that can result in GI bleed as well. Okay. Bloody diarrhea, mucus, you have ruled out dysentery. Bloody diarrhea, you also ruled out Crohn's disease, discomfort, bloating, and nausea. Why this?
Sir, abdominal distension, is there any obstruction over there to rule out that things? Right.
And then no history of altered sleep pattern, flapping, tremor, altered sleep. This is to rule out what?
Hepatic encephalopathy, sir.
Hepatic encephalopathy. Very good. Because in extra hepatic portal hypertension, there will be no hepatic encephalopathy, no such features. So, and if they are present, that will point in favor of the hepatic involvement. Next slide.
So no history of boiling passes of vomiting before development.
This is to rule out
gastric carcinoma, sir.
Gastric carcinoma in a 5-year-old child?
No, sir. But
Mallory waist tear.
Yes, sir.
And I told you it's a severe forceful emesis or retching that will result in a Mallory waist tear. Okay. Fever, bleeding from gums, and bone pains for?
Sir,
to rule out what?
To rule out hemat involvement, sir. There might be to rule out ALL, sir. Acute.
To rule out hematological, primarily leukemia, because you are asking about. Okay, very good, very good. Now, abdominal distension, constipation, you have already talked about. Hematuria, oliguria, why do you want to ask for that?
Sir, systemic rule out, sir. Is there any relation? Is there renal system involvement or not?
Which disease we talked about? One differential diagnosis of upper GI bleed. Henoch-Schönlein purpura. Okay. And then any involvement of other than CNS, heart, and cough. Next. Okay. Now you can come back to where you started. You were.
In my developmental history, the gross motor.
Let's go to the birth history. Birth and neonatal history is important. Natal history. This is important. Natal and postnatal. Why?
Sir,
Why this
is there
history of
any-
jaundice, NICU admissions you have written? This is important, very important. Why?
Yes, sir. Either the baby is born with some congenital defect or baby is born with some defect during the time of delivery, sir.
See, why most important history you have to ask at birth and immediately postnatal period is, one is whether there is any history of umbilical sepsis. And second, whether there was any history of exchange transfusion done because of jaundice. Because in both these cases, there is a risk of thrombosis that will be carried to the portal vein. And this thrombosis will ultimately result in a portal hypertension. So most of the time, this history is definitely to be asked for. History of any umbilical sepsis, history of any hemorrhagic, somebody's written HDN sepsis. Yes, that is also correct. But most importantly, for extrahepatic portal hypertension, always ask the history of umbilical sepsis and always ask the history of exchange transfusion in neonatal period. Okay, please go ahead.
Sir, in developmental history, the gross motor.
This is normal?
Yes, sir.
Okay, then I think we go ahead. So development is normal.
Yes, sir. And in dietary history, sir, there is some his daily requirement is 612 kilocalorie less than standard population for that age, sir.
Mm-hmm.
And protein intake is excess, that is 11.7 gram.
See, now you have written according to Holiday's formula for age and weight of population energy requirement. So that is a very rough estimate. So ideally, you should not be using this formula for calculating the energy requirement. You should look at the ICMR charts, and if there are any Nepalese chart available, so look at those charts for nutritional requirement of energy and protein at different ages. Okay, Ravi, you got me?
Yes, sir.
So that is preferable. What is the requirement at 5 years? Because recently there has been a huge change in these requirements. Previously, we used to think the requirements are high. Now the requirements are not that much that we have understood. Okay. So this child daily requirement is less than the standard population and protein excess that usually occurs in all Indian or Nepalese diet. Is a vegetarian, non-vegetarian? You haven't written that?
Yes, sir. He's mixed diet, sorry. Consume mixed diet, sorry. He's non-veg.
Okay. So that needs to be mentioned in the dietary history. Next.
In personal history, there is no significant medical and surgical history. Consume mixed diet, brushes 2 times a day, use slipper during toilet, and wash his hand with soap and water.
Why have you written this? Use slipper during toilet and wash his hand with soap and water.
Sir, to rule out waterborne disease, sir, because
which waterborne disease you think will result in GI bleed, upper GI bleed? Or you are just taking a general history?
Sir, taking general history, sir.
Yeah, but ideally, there is so many things to be asked, and in exam you have very limited time. So ask only things which are important. For general hygiene, okay, if general hygiene is good, that's what you want to say. Okay, let's move it.
Sir, family
Next.
history.
Yeah, next. No similar history in the family. Middle class family. Next. No known drug and allergic history. Okay, next. Fully vaccinated. Next. Okay, before we coming to differential diagnosis, can you summarize we will do differential diagnosis after we have done the examination.
Okay, sir. May I proceed for general survey, sir, or may I summarize the history?
Yeah, please go ahead.
Okay, sir. In general examinations, in general survey, my patient was ill looking, anxious, conscious, well oriented to time, place, and person, thin build, yellow cannula on both ends with body mass index 14.42 kg per meter square and was nearby 50th percentile.
Next.
In my vitals, the pulse rate was found to be 88 beats per minute, regular in rhythm, normal in volume, normal in character, condition of vessel wall is normal, no radio-radial delay, and no radio-femoral delay.
Okay, so your pulse rate is normal, your blood pressure is 100/60, respiratory rate 22, temperature afebrile, and SpO2 97. So what is your impression about the vitals?
Sir, vitals seem to be normal, sir.
Okay, why exactly you're looking at vitals? Why this is important in this case?
Sir, is the patient stable or not? Because there is blood loss is going on, sir.
Hmm.
And
So what will happen in the vitals if there is a considerable blood loss?
so there will be vital unstable, sir. The BP pulse rate might increase and the BP might fall, sir.
Okay, so you're looking for signs of shock. So
Yes,
this
sir.
child does not have any signs of hypovolemia or shock at present. The pulse rate is normal, the blood pressure is normal for age, and the child does not have any tachypnea, saturation is maintained. That means whatever blood loss was there was not that significant to result in hypovolemia or shock. Okay, next.
Sir, in my anthropometric measure examinations, the weight of the child is 15 kg, falling between.
Is it normal?
Yes, sir.
Okay, so let's leave it. Anthropometric examination is normal. There is no mild nutritional deficit is there, but the child is not having MAM or SEM. Rather than percentile, Ravi, nowadays we mostly talk about the Z score. Have you heard about what is Z score?
Yes, sir.
So it is always better that you say 10th percentile, or also say what is the Z score of the child of that, because that will give you, all classification now are based on Z score. So always mention, at least for the weight and height, what is the current weight and what is the Z score. That means what is -2 SD or 3 SD, whatever, between -2 and -3. So this needs to be mentioned. I'll just tell you, such as 85th percentile, okay, is equal to +1 Z score. 97th percentile is 2 Z score. And similarly, 15th percentile is -1 Z score, and 3rd percentile is -2 Z score. So ideally, you should be mentioning, because it is a Z score on which the WHO classification is based. Okay, mid-arm circumference is 14 centimeter, which is well within the normal. Next.
Proceeding for physical examinations, on 8 to 2 examinations, on oral cavity examinations, upper lip and lower lip seems to be normal. Buccal mucosa seems to be normal. No change of buccal mucosa color. Tongue seems to be normal. No bald and smooth tongue. No congenital fissuring of tongue. No throat ulcer. There is no hypertrophic gums, and there is no macroglossia, and there is no stipple line over the tongue, and no change in skin color in different part of the body. There is no PTG, chymosis, scratch mark, angiomas, xanthoma in different part of body. No leukonychia, no spider nevi, no bone swelling and tenderness, sir.
So what all you are ruling out in the head-to-toe examination?
Sir, there is no involvement of the upper, mainly, sir. From the I proceed with the oral cavity, sir. There is no involvement of the oral cavity. So the main and the tongue seems to be normal. And
What about the rest? There is no petechiae, chymosis. What does this mean? Why did you ask? Look for this.
sir, is there is any irritations is going on, or there is any chronic involvement is going on, not, sir?
This is petechiae ecchymosis don't occur because of chronic involvement. They occur because of involvement of hematological system, mostly in leukemia. So you want to find out, we want to find out if there is an upper GI bleed, is there any other area from which the child is bleeding? So we want to find out, is there a bleeding in the skin? So that's why this is important. Scratch mark, etc. It is because of some hepatitis or some obstruction which is leading to scratching. That's why you want to find out. Spider nevi, again, you want to find out to rule out again a cirrhotic liver. And bone swelling and tenderness, you want to find out again to rule out leukemia. So these are the reasons why you want. For every examination, for every negative history, you should have a reason why you did that in relation to the present case. We can go ahead.
Okay, sir. Sir, pallor present. There is no icterus, there is no palpable lymph node, no clotting, no cyanosis, no dehydration, and there is no edema, sir.
Okay. Pallor is moderate or severe?
Sir, pallor is moderate, sir.
Okay, let's go ahead.
In for abdomen examinations on inspections, the shape of the abdomen was slightly distended in hypochondriac region, umbilicus central and inverted, abdomen quadrant moving equally with respirations, hernial side intact, genitalia are intact, no visible pulse, no periumbilical ecchymosis, ecchymosis of one or both flanks, no edema of legs, no edema of groins and buttocks, no trophic white or pink stripe, no localized distension around umbilicus and above the pubic symphysis.
So what is your interpretation of the inspection of abdomen?
Sir, there is distension in hypochondriac region, sir, and other things are seems to be normal, sir.
What is the important thing you want to look in the inspection in a child who has a GI bleed? One is abdominal distension. So you said slightly, it is a localized distension. Hypochondriac region, that means which organ could be there?
Sir, there might be liver and gallbladder, sir.
Okay. Okay. What else?
Sir, there might be this ascending colon might be there, sir.
See, the most important thing you have not written in the inspection, you have not seen in the inspection, any visible or prominent veins. Abdominal, any distended veins over the abdomen, any caput medusae. These are the most important thing you want to look for if you're looking for a GI bleed which can be secondary to cirrhosis. Okay.
Yes, sir.
Next.
On palpation, sir, the feel of the abdomen is soft, and on superficial palpations, there is local rise in temperature in right hypochondriac lumbar region. And deep palpations, there is deep tenderness elicited over right hypochondriac regions. And then Carnett sign was negative, and the liver was palpable, and the liver span was 5.8 centimeter below the costal margin. Surface is smooth, well-defined. Margin of liver is sharp and well-defined with no pulsations. There is no presence of edema or tenderness overlying intercostal space. And there is palpable spring towards left 10 centimeter over costal margin to lowermost edge of the organ. Kidney bimanually not palpable. No tenderness and pitting edema. No any masses, no guarding and rigidity, sir.
Anybody will like to point out what is the mistake done here in writing the description of liver? What is the mistake in writing the description of liver? What do you understand by liver span, Ravi?
Sir, liver span means, sir,
how do you measure the liver span?
sir, initially we will proceed from right iliac region, sir, and on deep inspirations we find out the lower border of the and palpating liver from the right iliac regions, we move forward, and then when we palpate the lower border of the liver, then we point out a mark over there, and then from up, we from the second intercostal space of the right side, we begins to percuss over that region, sir. And
Okay,
when
so your definition is right, but you have written a liver span 5.8 centimeter below the costal margin. And at the same time, you are saying it is some part of the liver is above the costal margin and some part is below the costal margin, isn't it?
yes, sir.
So that is the liver span. So you can't say liver span below costal margin. Liver span means thoda upar hai, thoda niche bhi hai. So can you tell us liver, you can say liver was palpable 2 centimeter or 3 centimeter below costal margin and the liver span was 5.8 centimeter. Then it is correct. Do you understand?
Yes, sir.
I don't know whether you are getting me or not. Your definition of liver span was correct, but you don't say that the liver span is below costal margin because liver span includes the liver which is above costal margin and liver which is below costal margin. Okay, margin of liver is sharp.
Yes, sir.
Okay, this is very important. Margin of liver, sharp liver, what does it mean?
Sir, we are palpating the border, sir.
You're palpating the
Border, sir, inferior border.
What do you mean by, what is the implication of sharp liver? What is the normal margin? What is the normal margin of liver? Is it sharp and well defined or something else?
Sorry, sir.
Anybody else from the chat box? What is the normal margin of liver? आपने लिखा है margin of liver is sharp and well defined. Now, what is your interpretation? Is it normal or abnormal? Just tell me that.
Sir, it's normal, sir.
It is not normal, sir. It is not normal. Please understand, liver margin is never sharp. Normal liver margin. If you're saying, that means your interpretation of liver margin is incorrect. If liver is sharp, that means liver is sharp only when you have a hepatic illness, liver disease. Otherwise, liver is not sharp. Okay, please try to understand this. You go ahead and read what is the normal margin of the liver. Okay, then so most probably your liver should be, if it is normal, I think this should not be sharp and well defined. There should have been somebody to corroborate your finding, because I don't agree with this finding of sharp liver. If it is sharp, it is abnormal liver. And if it is abnormal liver, then it is unlikely to be extrahepatic portal hypertension. You see, you won't be able to defend your diagnosis. It is a smooth liver, yes. Normally is a smooth liver or a rounded margin. The margins are rounded. They are not sharp, normal liver margins. Okay, so there is a palpable spleen 10 centimeter and kidney is not palpable. Can go to the next slide.
And percussion, sir. Dull on right hypochondriac and upper right hypochondriac region. There is no shifting dullness, no podal signs, no distinct field present. Liver dullness from 5th intercostal margin to right hypochondriac region. Splenic dullness from 9 to 11 trip on left side. No hydratic trill. Tympanic in other quadrant of abdomen, sir.
So I just asked one question. Is there fluid in the abdomen? Is there ascites or no?
No, sir, there is no ascites.
There is no ascites because there is no shifting dullness, no puddle sign, and no distinct fluid release present. Next slide.
Sir.
Next.
Sir, rectal examination.
Next.
Could not...
CNS, CVS, and respiratory system were normal. Next.
Yes.
Now you summarize your case.
Yes, sir. 5-year-old male, a Muslim by religion, with conscientious marriage of his parent, presented to UCMS with history of vomiting of blood since for 1 day, passes of black color stools for 1 day, with past history of vomiting of fresh non-clotted blood before 1 year, with relief on blood transfusion and medications, with dietary history of a 37 kilocalorie energy, with developmental quotient 100, with pallor, with blood pressure fall in 90th percentile, with distended abdomen, with superficial rise in temperature and deep tenderness over right hypochondriac region and lumbar region, palpable liver span of 5 centimeter, and there is palpable spleen, sir.
Is that all?
Yes, sir.
Where has the spleen gone?
Sir, there is palpable spleen, sir.
I think that that is the most important thing of your examination, and you have not included it in your summary. You should have included it or not?
Yes, I should include that thing, sir. I forgot it, sir.
Because this child, this is a 5-year-old boy. See, when you summarize, you don't need to say, you have to give your interpretation. Just like it is a 5-year-old boy, Muslim by religion, there is no need to say the caste and all the consanguinity unless it is important in the case. It is a summary. So only important things need to be told. It is a 5-year-old boy who presented with 2 episodes of vomiting of blood, the first 1 year back and the second 1 day back, with black colored tarry stools, and in between without any other history. You have not written no negative history. So that is important. No history of jaundice, no history of abdominal distension, no history of encephalopathy. These are important things. No history of bleeding from any other site. This should have come in the summary. His dietary history was just mild nutritional deficit was there. Development, immunization was normal. That's how the history should have been. On examination, the child was pale. The vitals were maintained. The abdomen was distended, and there was liver. Liver was palpable with a span of 5 centimeter, and a spleen. There was a moderate to large splenomegaly of 10 centimeter. Moderate to large splenomegaly of 10 centimeter. That should have been your summary in this particular case. So if you are asked to summarize important points, there are 2 important points that emerge. One is the child is having repeated vomiting of blood, and second, the child has a big spleen. Now, if you have these 2 findings, one is history, one is examination, what will be your differential diagnosis? Now let's come to, you have any other slide left?
Sir, yes, this one, sir.
Differential diagnosis. See, the first thing is to make a provisional diagnosis. You have already written in your provisional diagnosis that you have made. In the list of differential diagnosis, you should mention in the frequency of their probability of occurrence. The most likely will come number 1. So which is the most likely diagnosis here in this child? What is the most likely diagnosis in this child?
Sir, portal hypertension, sir.
So why portal hypertension is at number 9? That indicates that portal hypertension ke upar the probability of the above 8 diagnosis is more. Whenever you write a differential diagnosis, the first differential diagnosis is the most probable. Second is secondly probable. That is in the order of sequence. Okay, it can't be that you can just write differential diagnosis in any sequence. I hope I am clear.
Yes, sir.
So first is your portal hypertension, then it will portal now you pick up all the causes here which will have GI bleed and splenomegaly, moderate splenomegaly. Tell me. Peptic ulcer disease will have?
They will be, sir.
Will have spleen of 10 centimeter or no?
No, sir, there will be no.
So it cannot be in the differential diagnosis.
Yes, sir.
Duodenal ulcer, can it have a spleen of 10 centimeter? No. Inflammatory bowel disease, yes, it can have a spleen, extrahepatic manifestation. So it can be there. Foreign body will not have a spleen. Coagulation disorder will not have a big spleen. Esophagitis will not have a big spleen. Swallowed blood from epistaxis will not have a big spleen, 10 centimeters. ALL, yes, could be a possibility. Gastric tuberculosis, what is the involvement of gastric GI tuberculosis is where? Which organ is affected?
Sir, ileum part normally affected or gastric part, sir?
So ileocecal is a gastric involvement. Why gastric tuberculosis should result in 10 centimeter of spleen? So out of these, your only portal hypertension will remain as number 1. Number 2, it could be a liver cirrhosis, which is unlikely, or ALL, and then maybe a coagulation disorder is also unlikely. So out of these, only 3-4 remain. The rest will not be in your differential diagnosis. Okay.
Okay, sir.
Now you tell me, why do you want to investigate? How will you investigate this child?
Sir, initially I will be sending the blood parameter, sir. In blood parameter, I'll be looking for level of hemoglobin, and then MCHC, and then PCV, and then I will be sending LFT, sir, to look for AST, ALT level. Either there is TRN's liver function test or not, and liver enzyme or not, and then I will be sending, sir, endoscopy to rule out where the bleeding is from, and then after that I will be doing, sir, CT scan, MRI, and also I will be doing chest X-ray over there, sir.
Somebody has written what could be the other differential diagnosis. See, you in this child, the ideal, don't straight away go to extrahepatic. You say, my differential diagnosis is most probably the child is having an esophageal or a variceal bleed. Okay. Now this variceal bleed could be because of portal hypertension. Portal hypertension, the most likely it could be prehepatic, it could be posthepatic, it could be intrahepatic. So my first probability will be a prehepatic, that is an extrahepatic portal hypertension, because this child is 5-year-old, does not have a firm hepatomegaly, does not have jaundice, does not have ascites, does not have any other features of coagulopathy, does not, on examination, there is no features of any liver involvement, there is no clubbing, there is no, you can say, ascites, I have already said, and then you can say that there is abdomen otherwise is normal. So this child most likely is having a extrahepatic portal hypertension. And the other differential diagnosis, any other, I will say maybe we'll want to rule out leukemia, but the history is of 2 years, so it is unlikely. The third is that it could be inflammatory, it could be Crohn disease, but again in Crohn disease, there are no extraintestinal symptoms, and there are no other GI or abdominal symptoms for that matter. So these will be the big spleen. Again, you can have another differential diagnosis, could be a splenic cyst or some mass in the spleen. It could be a splenic cyst. It could be a hydrated disease of the spleen. These could be the other possibilities which you can keep in mind. But again, these may not present with a GI bleed. So the most probably, you have to put forth your diagnosis and give the points in favor and points against. And then finally, as Ravi said, investigation will be, you will do a complete blood count. You will do a coagulation profile. That means prothrombin time, APTT and INR ratio. You will do complete liver function test. You will do stool examination. Then you will do an ultrasonography for features of portal hypertension. Then you will look for any inflammatory markers to rule out Crohn disease, such as CRP, perinuclear antineutrophil cytoplasmic antibodies, and anti-Saccharomyces ASCA antibodies. Then you will do a GI endoscopy, which is most crucial in this child. GI endoscopy can be both diagnostic and therapeutic. because it will allow the visualization of upper GIT. You can grade the varices. Ravi, are you aware of grading of varices?
Varices, no, sir.
Okay, so on endoscopy, you can grade as grade 1 to 4. Grade 1 is small varices. Moderate varices is grade 2. Large varices is grade 3. And very large varices is grade 4. This is very simple classification, but there are more things to this. So gastrointestinal endoscopy is very important. Then if you are thinking in terms of portal hypertension, extrahepatic, then you have to look for any portal vein thrombosis or portal vein malformation, any tumors. So you may like to do a CT angiography. So these are the various investigations you will like to do in this particular child. Okay. You'll also like to do a Doppler flow study. Portal vein is formed. You can switch off this slide, unshare the slide, because I think your slides are finished. We'll just now a few questions which you should be knowing about. What is portal circulation? How does portal vein form?
So by the splenic vein and the superior mesenteric vein, sir. Splenic
vein and superior mesenteric vein. Very good. So what is the pathophysiology of esophageal varices? There has to be some portal. In which portal veins are responsible for these varices? Esophageal varices, left gastric vein and lower esophageal vein. Okay, these are from the portal circulation, and lower branch of esophageal vein is from the systemic circulation. So similarly, if you have some rectal bleeds, if it is a rectal bleed, then your superior rectal vein is from the portal circulation, and your middle and inferior rectal veins are from the systemic circulation. So you should know this anatomy, which is important here. When do you say there is portal hypertension, what is the pressure in the portal vein? More than,
sir, 12, sir, 12 millimeter of mercury, sir.
More than
10 to 12, sir. 10 to 12 millimeter.
10 to 12 millimeter of
mercury.
Millimeter of mercury. Okay. Then what exactly, how do you diagnose portal? When do varices occur? See, there is a thing which is known as hepatic venous portal gradient. Hepatic venous portal gradient, which is measured. It's a difference between wedge hepatic venous pressure and then you subtract from it free hepatic venous pressure. So the difference between this is known as the gradient. Varices occur when this gradient is more than 10 millimeter Hg, and varices rupture when this goes beyond 12 millimeter Hg. So it is the intravaricial pressure which is important nowadays, which is measured so as to know whether they are near bursting or not. Okay, so let's say come to the management of this child. How will you manage this child? Final few minutes are there.
Sir, sir, initially we'll be looking for vitals, sir. After vitals, then we'll be proceeding with giving fluid, sir. Initially, after
this child is now stable. Why do you need? But the child doesn't need fluid. You said vitals are good. How will you manage this child?
Sir, I will be giving, sir, somatostatin analog, sir, a beta blocker.
Okay. So you can give somatostatin analog such as octreotide or vasopressin infusion. This is to stop the bleeding. Now the bleeding has already stopped. I think the whole management here in this child will depend on your endoscopic findings. What is the grade of the varices? And then what is the current treatment? It is the endoscopic variceal ligation. Okay, so you go for endoscopic variceal ligation. Sclerotherapy is a second drug. And previously we used to read about the shunt, the portosystemic shunts, etc. So they are only used when in extreme cases. So one could go for a splenorenal shunt or with the splenectomy or without splenectomy. There are different measures of surgery for that, but they are hardly required because variceal treatment, endoscopic variceal ligation is such a good treatment which is now available. You can otherwise you can also go for sclerotherapy. with the sclerosants such as ethanolamine and alcohol. So these are the various options that you will have in the management of this child. Okay. That's all from my side. Any questions?
Now we will like to go for the question and answer session. If the participants have any questions, I would like to request you all to write in the chat box, or if you want to directly interact with the sir, you can. The floor is all open.
Yeah, how to prevent rebleed? There is a question. Rebleed will occur whenever the esophageal, as I said, the hepatic portal venous pressure gradient is high. So you have to keep it low. That means one has to go for the, if the pressure is high, there you have to go for endoscopic variceal ligation. That is the best thing to prevent rebleed. Treatment plan, you have, see, firstly, you have, if it is an acute bleed, this child had a bleed one day back. Now the child is settled. But when the child is having acute bleed, the child should be given, as Ravi was saying, fluid resuscitation should be given, hypovolemia should be corrected, blood transfusion can be given to correct the blood losses, and then the child has to be given somatostatin analogs and vasopressin to stop the bleeding. And if, as soon as the child is a bit stable, immediately the best treatment is again to do a endoscopic sclerotherapy and variceal ligation. Other treatment modalities include H2 blockers, proton pump inhibitors. Okay, so these can also be tried in these particular cases. Any other question? I don't see. Okay, there is a big thank you, sir. That means there is no further questions. Okay, we're done. Thank you. Thank you so much, Ravi. Thank you so much, Abhigya. And thank you all my dear friends who are present today with me on this day. Thank you.
Now, on behalf of the Medicos team, I would like to request Mr. Susil Dakal Dai for the vote of thanks to our respected sir.
Thank you, Avigya. At first, I would like to thank Professor Dr. Piyush Gupta, sir, for mentoring today's program. You have been inspiring us, sir, motivating us through the live session and through your books as well, sir. Piyush Gupta, Clinical Methods in Pediatrics. Thank you so much, sir. I would also like to thank our presenter for today's program, Mr. Ravi Bashyal. It was a wonderful session. We got to know about a lot of things. And also, I would like to thank Abhigya Parajuli for successfully hosting this program. Thank you so much. And thank you everyone for being in this program. Thank you so much, sir, once again. Thank you.
Thank you so much. Thank you. And thank you for this big honor. It was lovely being with you.
Thank you so much, everyone. Now, for the floor, I would like to request our Professor Dr. Piyush Gupta, sir, for valuable words and any suggestions for us for our upcoming sessions. And how would you like to recommend us to improve furthermore?
Many, you're going great guns. I think it's just that we present more and we do more and more presentation. And when you're presenting the clinical finding, it is better that when you have the case, you click their photographs so that you can show the patient on when you are presenting, so that some idea is there, kaisa dikhta hai, liver kahan aapne mark kiya. You can take small videos when you are measuring the liver or you are measuring the spleen, you are doing ascitic fluid. So all of us can see, all of the other students can also see what is the correct method. And you can be told whether you are doing it rightly or not right. So that is the only thing that can be done to improve the presentation and discussions.
Thank you so much, sir. That was really valuable. And I hope our coming presenters would be addressing your valuable suggestions. Now,
thank you.
Thank you so much. Thank you so much, sir. And I also would like to thank you all of the participants for their valuable time and our professor. Now, I would like to end this session. I'd like to request the host.
Thank you, sir.